Thank you, Joe, but I think you lost a few friends after your talk. Sorry about that. Anyway, we'll talk later. It's my pleasure to introduce Dr. Raul Murillo, that has been doing a great work in Colombia. He's going to present phased implementation in piloting a national screening program in Colombia, and he works for the National Cancer Institute in the Division of Research and Public Health. Thank you.
Good morning. I would like to thank Dr. Ben Anderson and all the Breast Health Global Initiative staff for inviting us to present our results and for all the support and advice we have received for our pilot in Colombia. Let me talk a little bit about the context where we're conducting our pilot. This was presented by Dr. Fernando Perry yesterday, just to show that Colombia is not a high-risk country in the international scenario. And that's interesting because I think that it has driven the relative priority that has given to the breast cancer in our country. It should be different if we talk about cervical cancer, where Colombia would appear as one of the highest risk countries in the world. And of course, cervical cancer has received a lot more attention in our country than breast cancer. But if we look at the national data, we can see that breast cancer is accounting for the most cancer burden among Colombian women. It has the highest incidence and almost the same mortality as cervical cancer in Colombia. However, the response of our health system is not corresponding to the situation I just described. I should confess that our health system is quite complicated. I'm still trying to understand it, but I want to show you a little bit about its structure in order to make our data more understandable for you. This is prepaid medicine, is equivalent to private medicine, so I won't talk about that. We have in our health system, which is insurance-based, three main plans. One plan is health insurance for workers and their relatives, and it is provided by health insurance companies similar to the HMOs in the United States. And there is a portion of the population who received subsidized health insurance. They are the poorest and the lowest socioeconomic conditions in the country. And the health care is provided also through health insurance companies in the country. And there is about 50% of the population without any health insurance. If they need health care, they should go to public hospitals to receive that. And this is the mandatory breast cancer programs for the different plans. You may see here that there is mandatory screening with mammography every 2 years for women 50 and up, but it is required that the health maintenance organization should reach only 20% of the affiliated women to the HMOs. And you may see here that there are no mandatory breast care for the other insurance plans. And I'm not proud to show this because it is like saying that in our country, disparities are defined by law. And we look at the situation regarding breast care in a sample of 1,100 women in Bogota. These women were with breast cancer, and we review the time between the time elapsed between the symptom and the first consultation. We call that patient delay, and the time between the first consultation and the final treatment, and we call that health services delay. And you see here that about 66% of the women went for the first consultation in less than a month after the symptom appeared. But if you look at the time between the first consultation and the treatment, you can see that almost 70% of the women received the treatment after 3 months after the first consultation, implying a later stage of disease at the time of the treatment. The same study showed us that the breast cancer stage at diagnosis was stage 2B or more for 60% of the women in the study. Some data tell us that the epidemiological situation of breast cancer in Colombia is a kind of transition. We show here that the years of life lost from breast cancer and cervical cancer are quite different among the insurance plans. you see that the HMOs account for most of the year-of-life loss, and this is different for the cervical cancer than for breast cancer. And additionally, the geographical distribution of breast cancer mortality in Colombia showed that the biourban centers, which are marked in the green circles, are those who account with the highest mortality in the country. Again, if we compare this with cervical cancer and other cancers, the only pattern observed for this kind of distribution in urban centers was for breast cancer. We think that it is telling us that in our country, mortality is following incidence, as Dr. Harper mentioned before. The GDP is quite related greatly related to breast cancer incidence, but in our case, mortality is close to incidence because the lack of intervention of our health system. So with this context, the National Cancer Institute developed some guidelines for breast cancer early detection in Colombia. After a systematic review of the literature and a national consensus panel, we set up some recommendations for early detection. And we tried to move from a limited and enhanced scenario of breast cancer early detection. We used this for setting up this recommendation, the BHGI framework. The recommendations are not quite huge discoveries, but they tell us that you should strengthen early detection in symptomatic women based on breast self-examination and clinical breast examination. This is a big problem because usually primary care doesn't know what to do with a symptomatic women and breast symptomatic women. Regarding resources, the National Consensus Panel established that we wouldn't be able to reach all the target population, so we defined maybe the best option for us is to establish opportunistic screening with mammography every 2 years and CBE yearly in women 50 to 69. Also, we recommended to implement breast cancer early detection programs aimed at improving screening level of coverage, training of health professionals, access to diagnosis and treatment, and quality control of screening, both mammography and CBE. And finally, we have some recommendations about health education, breast cancer registries, and research. After setting up these recommendations, we decided that we needed to test the feasibility and the ways to implement the recommendations in our health system. So we started working on a pilot project for the introduction of breast cancer early detection programs in our country. Primary objectives of the pilot are to estimate the impact of the NCI guidelines in breast cancer downstaging, to estimate the impact of opportunistic screening on levels of exposure to mammography and clinical breast examination. I would like to say that we don't like pretty much to call that opportunistic screening because it means that it is a different level than organized screening. But in spite of being opportunistic, we need to organize the screening. So we like to call it more hospital-based screening, as I'm going to show you. To estimate the cost of implementing breast cancer early detection programs based on the NCI guidelines was the final primary objective for our study. This is the basic design. We designed a cluster randomized trial where a cluster is equivalent to a health center. It means that we randomized health centers, and it was stratified by HMO. It means that every HMO participates with at least 2 health centers, and we randomize health center within each HMO, and women go to the intervention or the control arm depending on the health center they're using for the health care. We expected, based on the data from the population-based cancer registry of Cali, breast cancer rate of about 100 per 100,000 women for the specific age group 50 to 69. I mentioned before that we look at improve our early detection stages from about only 30% to 60% of early detection stages. We need about 10,000 women in each branch of the study to get the differences we want to test. We did an intervention we'll describe shortly later, and after the recruitment of women and the intervention with screening, we will follow up the women 1 year because the incidence was based in a 1-year incidence estimation. And the comparison outcomes between branches are clinical stage, incidence, participation